Welcome to the deep dive. Today, we're tackling a really essential area for anyone stepping into nursing: hyperlipidemia, and the medications used to manage it. Think of this as your streamlined guide, the need-to-know info. We've looked at a range of sources to pull out the critical pieces you'll need. Keep it clear, keep it focused.
Absolutely. You're building this huge foundation in your fundamental nursing course. And, well, having a solid understanding of these meds is just paramount for safety, for effective care.
Right.
So our goal here really is to establish that groundwork. We'll explore how our bodies process fats, how high levels contribute to ASCVD, that's atherosclerotic cardiovascular disease, and then we'll navigate the main drug classes used to lower those lipid levels.
Okay, let's start right at the beginning then. Fat metabolism. When we talk lipids, we're mainly looking at triglycerides, phospholipids, and cholesterol, right? What's the job of each?
Yeah, exactly. Triglycerides, they're our body's main energy reserve. Think stored fuel. Phospholipids, they have a phosphate group. They're key for cell membrane structure, even involved in blood clotting.
Okay.
And then cholesterol. It's a steroid, vital for making steroid hormones, keeping cell membranes strong. We get it from food, sure, but our liver makes it too. A lot of it, actually.
So when we eat fats, what's that journey like? They don't just pop straight into the bloodstream, I guess.
No, that would cause some problems. It starts in the stomach, some initial breakdown. But the small intestine is where the real action is.
With bile acids.
Exactly. Bile acids, which contain cholesterol themselves, they act like detergents. They emulsify the fats, break them down into tiny droplets, micelles.
Cells, got it.
These get absorbed into the intestinal wall cells. And inside those cells, the fats get repackaged with proteins into bigger particles. Chylomicrons.
Chylomicrons. Okay, I've heard of those. They're the transport vehicles then. What's their specific job?
Precisely. Since fats and water don't mix, you need them. Chylomicrons carry these dietary fats out of the intestine, into the lymph system first, then eventually into the bloodstream near the heart.
Interesting. Lymph first.
Yeah. And the proteins on their surface, apoproteins, they're like address labels, guiding them. Some fats used for energy right away, some stored, some goes to liver for, well, more processing.
And that's where we get the different lipoproteins, like VLDL, LDL, HDL. Sounds critical.
It is. The liver takes these fats and packages them up. First, you get VLDLs, very low-density lipoproteins. Yeah. They're packed with triglycerides. Their job: deliver triglycerides to fat and muscle cells, energy or storage.
Makes sense.
As they drop off the triglycerides, they get denser. They become IDLs, intermediate density lipoproteins.
IDLs.
Yeah. These IDLs can either go back to the liver or get changed further into LDL, low-density lipoprotein, and LDL. That's the main cholesterol carrier in the blood.
LDL, the quote-unquote bad cholesterol. Why does it get that reputation?
Well, the issue is when these LDL particles, or maybe remnants of them, get trapped in the artery lining, there, white blood cells can basically gobble them up. This forms foam cells.
Foam cells.
And those are a key part of atheromas, those fatty plaques. It's a major step in developing atherosclerosis, the hardening and narrowing of arteries.
Okay, so LDL delivers cholesterol, potentially leading to plaque. What about HDL, the good cholesterol? How does it work?
HDL, high-density lipoprotein, plays a totally different role. Think of it as a scavenger.
A scavenger.
Yeah. It picks up excess cholesterol from tissues, including artery walls, and takes it back to the liver.
Back to the liver.
Right. And in the liver, that cholesterol can be used to make more bile acids, which eventually get eliminated. This reverse cholesterol transport is why HDL is seen as protective against ASCVD.
Interesting.
And things like regular exercise and estrogen in premenopausal women tend to bump up HDL levels. It's just probably part of their protective effect.
So when things get out of balance, these lipid levels, that's hyperlipidemia.
Exactly. Hyperlipidemia just means high levels of lipids in the blood, total cholesterol, triglycerides, LDL, VLDL. And yeah, it's strongly linked to a higher risk of ASCVD. Could be diet, could be genetics affecting how we handle fats.
And this ASCVD, it's not just the heart arteries, right?
No, good point. Coronary artery disease is huge, obviously. But this plaque buildup, this atheroma formation, it can happen in arteries anywhere.
Like legs, brain.
Yep. Peripheral arteries in the limbs, cerebral arteries in the brain. So hyperlipidemia raises the risk for stroke, peripheral artery disease, too. It all comes down to that gradual plaque buildup. Starts as fatty streaks, injures the endothelium. The inner lining triggers inflammation.
Inflammation plays a big role then.
A huge role. Yeah. Inflammation draws in more lipids, immune cells. The plaque grows, narrows the artery, makes it stiff.
We hear so much about risk factors for heart disease. Where do these elevated lipids fit in?
They're definitely key players. High cholesterol, other lipids, they accelerate that atheroma process. But, and this is crucial, they don't act alone.
Right. It's usually multiple things.
Exactly. Lots of factors contribute. We usually group them into unmodifiable things we can't change, modifiable things we can influence.
Okay, let's break those down. Unmodifiable first. What are the big ones?
Well, genetics. A family history of early heart disease bumps up your risk significantly. Age. Risk goes up as we get older. Can't stop that. And sex. Men generally have higher risk earlier on, but after menopause, women's risk shoots up, losing that estrogen protection.
Right. And the modifiable ones, that's where we as nurses can really intervene.
Absolutely. And there are many. Things like gout, cigarette smoking, that's a huge one, really jacks up the risk. Sedentary lifestyle. Diet, high saturated trans fats, processed sugar, lots of red meat, that's not great. Plant-based diets seem better.
Yep.
Then there's high stress, high blood pressure, high cholesterol itself, obesity, and diabetes. Diabetes is a big multiplier. Risk is like 2 to 4 times higher for heart disease.
Wow.
And there's even emerging research, looking at bacterial infections, autoimmune process that may be playing a role, still being explored.
You hear the term metabolic syndrome a lot too. How does that connect with hyperlipidemia and ASCVD?
Metabolic syndrome. It's like a cluster of risk factors all tangled together. It dramatically increases the risk for ASCVD and type 2 diabetes.
What's in the cluster?
Usually insulin resistance, extra belly fat, low HDL, the good cholesterol, high triglycerides, and high blood pressure. Often there's also low-grade inflammation and a tendency for blood clots. Having it is a major red flag for heart risk.
I know doctors use specific tools, calculators to figure out someone's risk. How do lipids fit into those?
Right. The ACCH, American College of Cardiology, American Heart Association, they have these risk calculators. The ASCVD Risk Estimator Plus is common. They plug in things like age, sex, race, total cholesterol, LDL, HDL, blood pressure, diabetes status, smoking history. And it spits out a 10-year risk score, sometimes lifetime risk too.
And that score helps decide treatment.
Exactly. It helps categorize patients low, borderline, intermediate, high risk. That guides how aggressive to be with lifestyle changes and whether to start meds like statins.
It's also really important to remember, isn't it, that risk isn't the same for everyone. There are cultural, ethnic differences.
Oh, absolutely. Critical point. Huge variations. For instance, people of South Asian descent often have higher ASCVD rates. Folks of East Asian descent might be more sensitive to statins, maybe need lower doses. Even within the Latino community, risk varies a lot based on specific background, probably due to differences in diabetes rates, metabolic factors.
And other groups.
Tragically, yeah. Native Americans and Alaskan natives tend to have higher rates of risk factors and disease compared to non-Hispanic white populations. We have to be aware of these disparities.
And for a long time, heart disease felt like it was mainly seen as a man's issue. How has our understanding changed regarding women?
Yeah, that's evolved a lot, thankfully. It's crucial we get this right. Heart disease is the #1 killer of women in many places, more than breast and colon cancer combined, often.
Wow.
Historically, women were underdiagnosed, undertreated. Research often focused on men. We now know women can have different symptoms for a heart attack.
Like what?
Maybe jaw or neck pain, unusual fatigue, shortness of breath without classic chest pain, nausea, indigestion. Things that can be missed.
That could definitely delay diagnosis.
It does. And then there's the hormone factor. Estrogen offers protection before menopause. After menopause, that drops off, risk goes up.
Didn't they try hormone replacement therapy for that?
They did.
Okay.
But longer-term studies showed HRT actually increased the risk of heart attack and stroke in some women. So it's generally not recommended now, just for heart protection.
So putting it all together, managing ASCVD sounds like it needs a really broad approach.
Precisely. It's multifaceted. You have to tackle as many risk factors as you can. Lifestyle changes are the absolute foundation.
Diet, exercise.
Right. Heart-healthy diet, lower saturated trans fat, less processed stuff, healthy weight, quit smoking, regular activity, managing stress. That's baseline. But often that's not enough. And that's where medications come in, as adjuncts.
Okay, perfect transition. Let's talk about those lipid-lowering agents. There are several different classes. Can you give us a quick overview? What are the main types?
Sure. The big categories are bile acid sequestrants, HMG-CoA reductase inhibitors, everyone knows those as statins, cholesterol absorption inhibitors, PCSK9 inhibitors, fibrates, niacin or vitamin B3, omega-3 fatty acids, and then a few other more specialized ones.
And they all work differently.
Yeah, each class hits lipid metabolism at a different point. Statins, for example, they mainly cut down cholesterol production in the liver, We'll get into the specifics.
And these drugs, they aren't usually the very first step, right? Lifestyle comes first.
In most situations, yes. Meds are usually added to lifestyle changes to boost the effect. Which drug or combo of drugs depends on the patient.
Depends on what?
Well, their specific lipid profile, is it mostly high LDL or high triglycerides, their overall heart risk, other health conditions they have, and importantly, potential interactions with other meds they're taking. It's tailored.
You mentioned earlier that drug choice and dosing can change across the lifespan. Can you expand on that a bit?
Yeah, that's important. In kids, say with familial hypercholesterolemia, that's genetic high cholesterol strict diet is first. But some fibrates, some statins are approved for them too.
Okay.
Adults, statins are often the first go-to for lowering cholesterol if they're at risk or already have ASCVD.
What about pregnancy?
Big consideration there. Statins are a no-go in pregnancy, category X, potential risk to the baby.
So what can be used?
If a drug is absolutely needed, bile acid sequestrants might be considered safer because they aren't absorbed systemically. But they can interfere with absorbing fat-soluble vitamins, which matters for mom and baby.
And older adults.
Often need lower starting doses of statins. Kidney function might be lower, and they can be more prone to muscle side effects, myalgia, even rhabdomyolysis. So careful monitoring.
Okay, let's dive into the specific classes, starting with bile acid sequestrants, like cholestyramine, clocelam, cholestyramine. How do these work?
Okay, so these work right in the gut. They bind bile acids in the intestine. Bile acids are full of cholesterol, remember?
Right.
This binding creates a complex the body can't absorb, so it gets excreted in the feces.
Taking cholesterol out with it.
Exactly. By getting rid of more bile acids, the liver has to pull cholesterol from the blood to make new bile acids. It ramps up its LDL receptors to grab more LDL from circulation, and result, lower serum cholesterol and LDL.
Interesting. So it forces the liver to use up cholesterol.
Precisely. And cholestyramine, interestingly, can also be used for itching, pruritus, sometimes caused by partial bile duct blockage.
And these drugs, they stay in the gut, not absorbed into the body.
Largely, yes. Their action is mainly in the intestinal lumen. They get eliminated in the feces. Cholestyramine is a powder you mix. Cholestyramine is powder or tablets. Cholecyvelum is tablets. Patients need to know how to take them correctly, usually with meals to bind the bile acids from food.
Are there times when they absolutely shouldn't be used? Contraindications?
Yep. Allergy to the drug, obviously. Complete biliary obstruction because they need bile acids to work. And caution, with abnormal intestinal function, they can make things worse.
And pregnancy lactation?
Caution there too, because of that potential to reduce fat-soluble vitamin absorption. But again, maybe the safer drug option if one is essential during pregnancy.
What about side effects? What do patients commonly experience?
Mostly GI stuff. Constipation's a big one, can be really bothersome, even lead to impaction. Nausea, bloating, maybe making hemorrhoids worse.
Anything else?
Headaches, anxiety, fatigue, drowsiness sometimes. And because they can mess with vitamin K absorption, maybe increase bleeding time in some people. Long-term, potentially low levels of vitamins A and D, rash, muscle aches are less common.
And drug interactions. Since they work in the gut, do they interfere with other meds?
Oh, definitely. They can significantly decrease the absorption of lots of oral meds. Fat-soluble vitamins A, D, E, K, vasodiuretics, digoxin, warfarin, thyroid hormones, birth control pills, corticosteroids. The list is long.
So timing is key.
Absolutely. The general rule is take other oral meds either 1 hour before or 4 to 6 hours after the bile acid sequestrant. And yeah, women on oral contraceptives might need a backup method.
Nursing-wise, what are the main things to keep in mind for a patient on these?
Assessment is huge. Check for contraindications. Get a baseline on bowel function. Get a really good medication history, including supplements.
And administration?
Make sure the patient knows exactly how to mix and take it, timing with meals, timing with other drugs. Monitor their bowel habits closely. Watch for vitamin deficiency signs. Check labs as ordered. And lots of patient education, how to take it, side effects to report, and reinforcing that diet still matters.
Okay, let's pivot to the big ones. HMG-CoA reductase inhibitors. Statins. Everyone knows statins. How do they work their magic?
Right. Statins target a key enzyme in the liver, HMG-CoA reductase. This enzyme controls the rate-limiting step in making cholesterol in the liver.
So they block cholesterol production?
Essentially, yes. They inhibit that enzyme so the liver makes less cholesterol. This drop in liver cholesterol makes the liver put out more LDL receptors on its surface.
Why more receptors?
To grab more LDL cholesterol from the blood, those receptors pull LDL out of circulation. So you get a big drop in serum cholesterol, especially LDL. They also give a little boost to HDL, the good stuff, and slightly lower triglycerides.
And they might have other benefits too.
Yeah, seems so. Beyond lipids, they appear to reduce inflammation in blood vessels, help stabilize plaques. These are called pleiotropic effects. Adds to their overall heart benefit.
So less production in the liver leads to more clearance from the blood. That's the main idea.
That's it. And they're really a cornerstone for treating high cholesterol, high LDL, high triglycerides, especially when lifestyle isn't enough. Also used to slow down existing ASCVD progression, prevent heart attacks, strokes, need for procedures in people at risk.
They get categorized, right? High intensity, moderate.
Yeah, based on how much they lower LDL, high, moderate, low intensity. Helps guide which one and what dose. Atorvastatin, rosuvastatin at higher doses are high intensity. And you often see them combined with other drugs, like Ezetimibe, for even more LDL lowering.
How does the body handle statins? Absorption, metabolism?
They're usually well absorbed orally, but they undergo a lot of first-pass metabolism in the liver. That's where they work most.
How are they eliminated?
Mostly in the feces, through bile, some in urine. Peak effect usually takes 2 to 4 weeks. Most are once daily, some best taken in the evening because liver cholesterol production ramps up at night.
And the pregnancy issue again?
Critical point.
Yeah.
They cross the placenta, get into breast milk, absolutely contraindicated in pregnancy and lactation, potential harm to the baby.
So when should statins absolutely not be used or used very carefully?
Contraindicated if someone's allergic, obviously. Also with active liver disease or persistently high liver enzymes with no explanation. And again, pregnancy and breastfeeding.
Where do we need caution?
Caution if there's a history of liver problems, even if not active. Significant kidney impairment. Some statins need dose adjustments. Risk of muscle problems is higher. Maybe impaired endocrine function too. Potential interaction with hormone production, but less absolute.
What about side effects with statins? What should nurses be watching for and teaching patients about?
Common ones are often mild GI things, gas, abdominal pain, cramps, nausea, vomiting, constipation. Some people report CNS effects too. Headache, dizziness, blurred vision, trouble sleeping, fatigue.
And the more serious concerns?
Liver enzymes need watching. Statins can cause liver toxicity, though serious damage is rare. The bigger worry is myopathy, muscle pain, tenderness, weakness.
That can lead to rhabdomyolysis.
Rarely, yes. That severe muscle breakdown can damage the kidneys. Risk is higher in older adults, people with low body weight, hypothyroidism. It's rare, but serious.
Are there major drug interactions we need to know about?
Absolutely. Statins are broken down by liver enzymes, mainly the CYP system. Other drugs can inhibit these enzymes.
Like what?
Strong CYP3A4 inhibitors, certain antibiotics like erythromycin, antifungals like ketoconazole, also other lipid drugs like fibrates, especially gemfibrozil, and Ezetimibe. Using these together can raise statin levels, increasing risk for myopathy and liver issues.
Okay.
Careful dosing, close monitoring needed.
And grapefruit juice.
Ah, yes, the famous one. Patients need specific warning about grapefruit juice. It inhibits CYP3A4 in the gut, can significantly boost statin levels and toxicity risk. Avoid large amounts.
So nursing care for statins, what are the key takeaways?
Assessment again, history for contraindications, risk factors, baseline liver and kidney function tests, any current muscle pain during therapy. Monitor cholesterol LDL for effectiveness. Check liver function tests periodically. Maybe kidney function for some patients.
And patient teaching.
Absolutely vital.
Ah.
Stress adherence to diet exercise. Explain common and serious side effects. Critically important. Tell them to report any unexplained muscle pain, tenderness, or weakness right away. Remind about grapefruit. Reinforce the pregnancy contraindication.
Okay, let's move to cholesterol absorption inhibitors. Ezetimibe is the main one here. How does this one work?
Ezetimibe is different. It works right at the brush border of the small intestine. It selectively blocks the absorption of cholesterol from the diet.
So less cholesterol gets in from food.
Exactly. Less dietary cholesterol absorbed means less delivered to the liver. The liver then, again, compensates by increasing LDL receptors to pull more cholesterol out of the blood. So serum cholesterol and LDL go down.
But maybe not as proven for reducing actual heart attacks or strokes on its own?
Right. Clinical trials haven't consistently shown the same level of CV event reduction with ezetimibe alone compared to statins, but it's valuable as an add-on.
So it targets absorption, not production like statins. Key difference.
Exactly. Often added to a statin if LDL goals aren't met, or maybe used if someone can't tolerate statins. Less commonly used alone for primary prevention. Can also be combined with fibrates for mixed hyperlipidemia sometimes.
How is Ezetimibe handled by the body?
Pretty well absorbed orally. Peak levels in a few hours. metabolized in the liver and small intestine. Has a fairly long half-life, so once daily dosing works. Mostly excreted in feces, some in urine. We don't have great data on placental transfer or breast milk, so caution in pregnancy lactation, especially if combined with a statin.
Any specific contraindications or cautions for Ezetimibe?
Main one is allergy to ezetimibe itself. If it's combined with a statin, then all the statin contraindications apply to pregnancy, lactation, severe liver disease. As monotherapy, use cautiously in pregnancy, lactation, older adults, and those with liver disease.
What about side effects? Is it generally well tolerated?
Usually, yes. It has a pretty good side effect profile. Most common are mild things like abdominal pain, diarrhea, less bloating or gas than with sequestrants or fibrates.
Any others?
Headache, dizziness, fatigue, upper respiratory infections, back pain, muzzle aches have been reported. Rare cases of liver inflammation, hepatitis have occurred too.
And drug interactions for Ezetimibe?
Yes, a few important ones. Bile acid sequestrants can reduce its absorption, so take Ezetimibe 2 hours before or 4 hours after them.
Okay.
Combining with statins, as mentioned, increases risk of myopathy and liver issues, needs monitoring. Using it with cyclosporine or fibrates can increase Ezetimibe levels, potentially boosting toxicity risk, and there's a higher risk of gallbladder problems when used with fenofibrate.
What about warfarin?
Potential interaction there too. Ezetimibe might increase warfarin levels, so need close INR monitoring if patient takes both.
Nursing considerations for Ezetimibe?
Check for allergies, baseline liver function, monitor cholesterol lipids for effectiveness, monitor liver function periodically, especially if combined with a statin, and patient teaching. Keep up the diet, exercise, report side effects, and be clear on timing with other meds, particularly sequestrants.
Okay, now for a newer class, PCSK9 inhibitors, Elerhumab, Evolocumab. These sound like a big step forward for really high LDL. How do they work?
Yes, they're a novel and very potent approach. PCSK9 is an enzyme, protein convertase sublysin type 9.
Catchy name.
Right. This enzyme normally binds to LDL receptors on liver cells and causes them to be broken down.
So it gets rid of the receptors that clear LDL.
Exactly. Fewer receptors mean less LDL cleared from the blood. PCSK9 inhibitors are monoclonal antibodies. They block that enzyme.
So they stop the enzyme from destroying the receptors?
Precisely. By inhibiting PCSK9, you prevent LDL receptor degradation. You get way more LDL receptors on liver cells. This dramatically boosts the liver's ability to pull LDL out of the blood. You get really significant LDL reduction, often much more than with statins alone.
So different again, not production, not absorption, but enhancing the body's own clearance mechanism.
That's it. Because they're so potent, they're used to cut risk of heart attack, stroke, revascularization in adults with CVD who need more LDL lowering. Also approved for primary hyperlipidemia, including genetic forms like familial hypercholesterolemia, which can be really tough to treat otherwise.
How are these given? Pills?
Nope, subcutaneous injection. Bioavailability is pretty good, 70–85%. Reach steady levels after a few doses. They're large proteins, long half-lives, like 11 to 20 days.
How are they broken down?
Just normal protein breakdown pathways. Safety in pregnancy breastfeeding isn't fully established, so caution there.
Any specific contraindications or precautions nurses should know?
Main one is a history of serious allergic reaction, hypersensitivity to the drug.
And potential side effects, since they're antibodies.
Yeah, potential for immune effects, but usually mild. Most common things are mild infections, colds, UTIs, upper respiratory infections. Injection site reactions are also common. Redness, itching, swelling at the site.
Allergic reactions?
Possible. From mild rashes to, rarely, more serious things like vasculitis, inflammation of blood vessels, but severe reactions are uncommon.
Do they interact much with other drugs?
Generally, they can be used with other lipid meds like statins or Ezetimibe without needing dose changes. They don't seem to go through that CYP enzyme system much, which avoids many common interactions. Studied less in severe kidney liver disease, but usually no dose adjustment needed for mild, moderate cases.
So nursing care for PCSK9 inhibitors, what's key?
Check for history of hypersensitivity. Ask about current infections. Since they're injections, patient education on self-injection technique is critical. Proper site rotation, preparation, disposal.
And monitoring.
Monitor for injection site reactions. Educate patients on signs of allergic reactions. Tell them to report immediately. And of course, monitor cholesterol LDL levels to see how well it's working.
Okay, last category, the other agents. Can you briefly touch on fibrates, niacin, omega-3s, and those newer ones like bempedoic acid and lamidopide?
Sure. Let's run through them. Fibrates, fenofibrate, gemfibrozil. They mainly slash triglycerides. Can also raise HDL. Variable effect on LDL.
Any big watch-outs?
Big one is myopathy risk, especially with statins. Gemfibrozil plus a statin is generally a no-no. Fenofibrate can raise uric acid, risk of gallstones.
Right.
Caution with warfarin to bleeding risk.
Okay. Niacin, vitamin B3.
Complex mechanism. Inhibits fatty acid release, boosts triglyceride removal, lowers LDL triglycerides, and notably raises HDL. But side effects often limit use.
Like what?
Flushing is classic. Nausea, abdominal pain. Can also raise uric acid, bad for gout patients. If used with sequestrants, take niacin at bedtime, hours after the sequestrant.
Omega-3 fatty acids, fish oil.
Primarily lower triglycerides. Prescription forms like omega-3 acid ethyl esters, icosapent ethyl exist. Icosapent ethyl actually showed reduced CV events in high-risk patients on statins with high triglycerides.
Considerations.
Can prolong bleeding time, caution with anticoagulants, fish allergy caution. Icosapent ethyl specifically has a risk of atrial fibrillation or flutter.
Bempedoic acid, newer one.
Yeah, oral med. Inhibits cholesterol synthesis differently than statins. Used as an add-on to statins for familial hypercholesterolemia or ASCVD needing more LDL lowering, potential for high uric acid, tendon rupture risk.
And lomitapide.
Also newer for homozygous familial hypercholesterolemia, the very severe genetic kind. Inhibits MTP protein needed to make VLDL chylomicrons. Lowers LDL that way.
Downsides.
Big one. BOST warning for liver toxicity. It's under restricted access program. Also messes with fat-soluble vitamin absorption. Needs supplements. Contraindicated in pregnancy lactation.
Wow. And sometimes combining these different drugs is needed, but sounds like extra caution is required.
Absolutely correct. Combination therapy can be great, hitting lipids from different angles. Statin plus ezetimibe is common for more LDL lowering. But yeah, additive side effects are a real concern. Statins plus niacin or gemfibrozil equals higher myopathy risk. Always weigh benefit versus risk. Monitor closely.
Okay, we have covered a tremendous amount of ground today. Really crucial information on hyperlipidemia and its management. To wrap things up for our listeners, can you give us a concise summary, the key takeaways?
Sure. So hyperlipidemia, it's a major, very common risk factor for ASCVD, a leading cause of death. Understanding basic lipid metabolism, the fats, the lipoproteins, is key to understanding how these drugs work. We have multiple classes of meds targeting different points in that metabolism. Each has unique mechanisms, uses, contraindications, side effects, interactions. Nurses must know these.
And the nursing role.
Vital.
Yeah.
Careful assessment, safe administration, monitoring for effectiveness and side effects, and comprehensive patient education. Medication and lifestyle.
And it's worth saying one last time, right? Meds work best alongside those foundational lifestyle changes.
Absolutely. Heart-healthy diet, regular activity, healthy weight, no smoking. Managing stress, that's the cornerstone for preventing and managing hyperlipidemia, reducing ASCVD risk. Meds are vital adjuncts, but they don't replace lifestyle.
So as future nurses, you'll be right there, educating patients on managing lipids, lowering risk. Think about all the individual things that affect how well these meds work, how well patients can stick to lifestyle changes, what questions will your patients have, and where can you find reliable, up-to-date info to guide your practice and provide that compassionate care. It's definitely a complex field, always evolving. Lifelong learning is key. Thanks for joining us for this deep dive.